Please stand by while your recording connection is established. This conference is being recorded.
Okay, you can start. I'll tell Amber to tell her how to log in.
Good morning, everyone. Thanks for joining us today. This is our second webinar in the series of webinars we've had so far. The one we had on Wednesday was introduction and pretty much an overview of the institutes, the way they're structured. We'll also cover some of that in some detail and some capacity throughout this webinar, just in case some of you missed that one. With me today, my name is Tony Ochoa, and with me I have
Betsy Morales.
And the topic of today's webinar is stigma and cultural competency in HIV prevention. Before we get into the topic, we're going to have a quick overview of who we are as an agency and kind of a little bit about the tracks and the institutes and kind of the way they're structured and how we managed to create them and how they were developed. So just to let you guys know, the lines are currently muted. If you have any questions, feel free to enter your questions through the chat box. With that, we have our colleague Amber Channer, who will be the person moderating the chat function. We also will have periods throughout the webinar where we'll unmute the lines for people to ask questions. We've kind of designed this webinar to be pretty interactive as far as webinars can go. There are several polls throughout the webinar where we'll ask a series of questions and ask you guys for your feedback and allow you guys to select answers to those questions. If there's anything else we missed, feel free to ask in the chat function. And again, we'll looking forward to interacting with you guys today. Another reminder is that we will have this webinar recorded. This webinar is being recorded so that we can allow colleagues that aren't able to attend today view it later. So in case you want to be mindful of anything you might want to bring up that might be sensitive, be mindful of the fact that this is being recorded. So let's get started. Again, like I said, with the Latino Commission on AIDS, a little bit on our background. We were founded in 1990 by our president, Dennis De Leon, who served as president between 1994 and 2009. We do work locally, regionally, and nationally, and survive services in more than 40 states, including Puerto Rico and the Virgin Islands. Our four core areas encompass HIV behavior research, HIV prevention and health promotion, capacity building, which is the branch that we're a part of, and the part of the branch that's going to be implementing institutes in Texas, HIV testing and access to care, health policy, and community mobilization. And to speak a little bit more in depth about the branch I just mentioned, the capacity building branch, those have two areas of focus. The first one being Hands United, or Manos Unidas, in which our goal is to work with community-based organizations and provide them with technical assistance in three different areas. Those areas being organizational infrastructure and program sustainability, evidence-based interventions and public health strategies, and the last one being monitoring and evaluation. And we work across all ethnicities and all races and backgrounds. So even though we're the Latino Commission on AIDS, we work with organizations that don't necessarily focus on that target population. Another thing to add on is that all the services we provide are free of charge. So any community-based organization that we work with, our services are completely free. The second branch is Comunidades Saludables Ahora, or Healthy Community Now. And the goal of this branch under the SIVA division is to increase access to utilization of HIV prevention services among Latino nationalities through the implementation and dissemination of community mobilization models. And these three models are mobilizing emerging populations, which is mainly focused in the South right now with their Deep South project. The second one being Latino religious leadership, in which we build relationships and help organizations and coalitions build relationships with non-traditional partners in the faith-based community. And the third one, Latino AIDS Awareness Day. And lastly, Hispanic Healthcare Worker Mobilization, which works with service providers in the healthcare field to help them increase their capacity and competency around working with Latinos. So that's kind of an overview of what our division looks like. Next we'll be talking about the institutes themselves. So the way we created these institutes was we went ahead and conducted a needs assessment. And we did this by 3 different areas. The first one being an online survey, and this was disseminated through dishes. And we had about 115 respondents that replied to this online survey through SurveyMonkey. It was a pretty well mixed group of people. So we got a lot of people that were administrators, line staff, and working in rural environments, urban environments, suburban areas. So it was a very diverse group of respondents that we had respond to the survey. We also conducted a review of existing data. Along with that, we also did key informant interviews with colleagues in Texas, just so that we could get a better scope of what's going on, the type of environment that is currently brewing in Texas in terms of HIV and AIDS. So from this, we managed to capture information, and some of the findings we had are listed here, where we realized there's a high level of experience in Texas in terms of the services being provided. People really want to be able to enhance their partnerships with other organizations. There's a want to kind of develop a network of service providers. Service providers want to better be able to understand the community. They want up-to-date information, especially now in a time where we have the national HIV/AIDS strategy coming into play. People want to be able to adapt to what's going to be coming and the changes that are going to be taking place. Organizations want to learn how to be better sustainable, and people also want to develop their own skill set and improve their delivery of services. So they want to be able to develop their own workforce or develop their own implementation of their work. So the outcome was that, knowing that people in Texas is such a large state, people would probably have a hard time going to one particular location if we only had one institute. So we decided to break it up into several locations. The first location being in San Antonio on February 7th. The second one is a community forum. So there won't be a series of tracks, or what we're designating as tracks or courses, but it will be a community forum where we'll have a dialogue with people in the community over issues that are ongoing in Texas in terms of HIV and AIDS. The second series of tracks, which is a duplicate of what's going to be covered in San Antonio, is going to be covered in Dallas on February 9th. And in the future, we'll be having another series of tracks implemented in Houston in April. So that's kind of an overview of the way the tracks were kind of developed, and where what some of the findings were, and how we kind of went about creating the way this is laid out. We'll go into detail as to what each track is and the way the tracks are laid out throughout the day at the end of the webinar. So we'll go into more detail for that in a minute. Just some housekeeping rules. If you do have a question that you want to bring up during the course of the webinar, feel free to unmute your line by pressing *7, and you can go ahead and mute your line again once you're done speaking by pressing *6. Like I mentioned at the beginning of the webinar, we have our colleague Amber who will be monitoring the chat function, so you can also use the chat box to ask any questions in case you feel kind of shy. So just to get the ball rolling, we're going to go ahead and unmute the line for a second, just so people can introduce themselves. So tell us your name and your place of work. You can also chat that information in the chat box. So go ahead and just give us your name and where you're from and what you do. So we're unmuting the lines now.
The conference has been unmuted.
Hi, this is Adriana DeBello with Houston, Texas at ALMA, and I have Yadira Aguilar, Manuel Valentin, Rick Cepeda, and Linda Garcia.
Great, welcome.
And also Stephen Vargas from ALMA.
Great, thanks for joining.
And also Ashley Ennis from AZARM.
Okay.
Thanks, Ashley.
Anyone else?
We have.
And this is Omar Lopez with Austin Travis County Integral Care, and I'm a risk reduction specialist.
Okay, thank you.
Hi, this is
Go ahead.
Hi, this is Antonio Martinez calling from International AIDS Empowerment in El Paso, Texas.
All right, welcome.
This is Gallego with the state of Texas, DSHS, Mental Health Substance Abuse, the HIV, SAMHSA, Black Panel Coordinator.
Welcome.
Yeah.
Good morning, everybody. This is Monrovia Van Hoos. I work for Out Youth in Austin. I'm the clinical director at Out Youth and also the coordinator for our HIV testing and risk reduction program.
Great.
Hi, this is Ann Freeman from UT Southwestern in Dallas.
Welcome.
This is Julian Vasquez from Dallas, Mosaic Family Services. I'm a counselor here.
Great.
Hi.
None. Go down and put none. And say something about not going face to face.
Okay. And then we also have some people that have entered in the chat box.
We have Demetria, we have Alice, we have Florice, Shantae, Sine, Celicia, Giovanna, and Daniela. So,
Danielle.
I'm sorry, Danielle. Great to have you guys all on the line. As you can tell, when we unmute the lines, it can get kind of hectic. So that's why we're going to go ahead and mute the lines now once we get started. So thanks again for joining. And feel free to continue asking questions through the chat box.
The conference has been muted.
Okay, so one more thing is that another way that you can talk to us, you can raise your hand and we can unmute your line, or you can go ahead and do it yourself like Tony mentioned earlier.
So today's webinar agenda, to give you a brief overview, it's kind of going through the basics of defining and describing what stigma is, explain the difference between stigma, discrimination, and prejudice, identify the common stigma in your organization, the relationship between stigma and culture, explain the relationship between stigma and social marketing, discuss the direct implications of stigma with HIV prevention efforts, definition of cultural competency, and techniques for cultural competent services. Things to keep in mind are how does this information impact your worldview and as well as your workplace. So keep those two things in mind while we're discussing some of the topics throughout the webinar. So to get the ball rolling.
So let's begin with stigma. So we want to ask you guys a question. Tell us, what is stigma to you? And we want you to go ahead and answer that.
So read them first, read these through. So we have, what is stigma to you? A, being a negative label given to someone because of a certain characteristic. B, being a distinction made against someone based on prejudice. Or C, an unfavorable question formed beforehand. So once you've selected your answer, we're going to go ahead and now give you guys the function to click what you think your answer is. So click on what you think it is. Is it A, is it B, or is it C? So we're gonna go ahead and close the poll now, just so that we can all see what the respondents, what everyone responded. As you can see, the majority of people said it was C, followed by A and C. So again, just to review again what those were, we have the majority of people said they thought it was B, a distinction made against someone based on prejudice, followed by A, a negative label given to someone because of a certain characteristic, and lastly we had an unfavorable question formed beforehand.
And those, all of those, and these are just basically different ways that we all may think about stigma. But when we look at, we can actually look at a specific definition that we've been given, and the definition is Stigma is identified as an attribute or label that sets a person apart from others and links the labeled person to an undesirable characteristic. So, okay, so what is it? What is stigma? When we stigmatize an individual, is to give them a negative association or connection with a characteristic, and these characteristics can be physical. So, for example, people that are disabled, that may be in a wheelchair or that may be missing a leg or an arm. The characteristics can also be concealable. So things like cancer, for example, hepatitis C, HIV. So these are also characteristics that may give that negative association or connection. Other characteristics can be tribal characteristics. So, for example, things that come from a person's race or religion. And then things like if a person is homosexual or political views, things like that. And then from these associations, the individual will be constantly vulnerable to negative criticism or emotion from those around them. And some of these emotions or negative criticisms can be things like a negative evaluation, rejection, a person being ostracized or teased, and discrimination. And we've seen this, I'm sure you've all seen this, and when we go through these things, these different parts of stigma, we want you to keep in mind, have you ever felt stigmatized, or in this case, have you ever have seen these reactions towards you? So some type of rejection or teasing or something. So maybe because of your accent or the way that you look or the way that you dress or the way your hair is or the way that you speak. So different things that can cause stigma. And I want you guys to think about how you felt when if this ever has happened to you. How did you feel about this?
Great. So we're going to have another question, and this is a more lengthier question, so make sure you pay attention and read it into a little more depth. The question being, which of the following do you feel is the largest contributing factor to HIV/AIDS related stigma? So A is HIV/AIDS is a life-threatening disease, and therefore people react to it in strong ways. B, HIV infection is associated with behaviors such as homosexuality, drug addiction, prostitution, or promiscuity that are already stigmatized in many societies. C is most people become infected with HIV through sex, which often carries moral baggage. D, there is a lot of inaccurate information about how HIV is transmitted, creating irrational behavior and misperceptions of personal risk. E, HIV infection is often thought to be the result of personal irresponsibility. Or F, religious or moral beliefs lead some people to believe that people infected with HIV is a result of moral fault, such as promiscuity or deviant sex, that deserves to be punished. So now that we've gone through each one, think about which one you want to select, and we're going to open the poll up now. So here we have the poll. Select which answer you think is best fit.
Did you put in the survey at the end? The evaluation?
Okay. You see, about most everyone's responded so far. So we're gonna go ahead and show the results. Okay. So we see that the majority of people chose B. It seems like people really like the letter B this morning. B is HIV infection is associated with behaviors such as homosexuality, drug addiction, prostitution, or promiscuity that are already stigmatized in many societies. So, and the second one was D. And D again was there is a lot of inaccurate information about how HIV is transmitted, creating irrational behavior or misperceptions of personal risk. So thanks again for submitting your answers to that. And it's just really interesting to see what people think and what people believe. So hopefully people will find this beneficial. So let's talk about stigma as it relates to AIDS and HIV. It seems that even though we're 30 years into the epidemic, stigma has been something that's been a constant struggle even from the beginning, which is letting us know that there's still a lot more work to be done. Stigma as related to AIDS has been defined as the prejudice, discounting, discrediting, or discrimination that are directed at people perceived to have AIDS. So notice that it says perceived to have AIDS. So there's definitely some sort of visual cues that people are considering or viewing as someone that would have AIDS based on physical attributes. So that person might not necessarily have AIDS, but there's definitely some sort of visual attachment to it. Second, persons with AIDS are often considered morally corrupt, that they engage in immoral behaviors, and that they do not respect their bodies. Because of these beliefs, PWAs, or people with AIDS, are often discounted or dismissed. So, what is stigma? So there's different dimensions to stigma, right? So we have concealability, coarse, disruptiveness, aesthetic, origin, and danger. So concealability has to do with how much can someone hide something that they might be stigmatized about. So an example of this is something very concealable might be religion, or diseases which is not readily visible, while high unsealable ones would be something like skin color or missing limbs. Another dimension, like I mentioned a minute ago, is coarse, and coarse is something that changes over time. So you can think of this as certain diseases where visual aids or visual cues might come into play when someone's become more ill throughout the course of the illness. Disruptiveness. How much is something affecting interpersonal interactions with someone? How much is some sort of something that can be stigmatizable affecting someone, the way someone can interact with you? Aesthetic. How does it look? Is it something that's normalized, something that's not so normal? The origin. How and who is responsible? How controllable was the onset of something that you're being stigmatized about? And finally is danger. How dangerous is this thing that someone's stigmatized about in order of infecting someone else or causing harm to others? So these are the 6 dimensions of stigma that we want to address throughout the webinar.
And when you're thinking about stigma, some of the things that we have to think about is how this has been portrayed in our communities. And what we're going to do now is we're going to look at how marketing techniques have reinforced stigma in our communities. So we're going to look at a couple of marketing campaigns, and here we have 2 marketing campaigns, and let's see. So what do you guys think about these campaigns? We're going to unmute the line for a few minutes, and just so that you guys can tell us, what do you think? What do you see here? What I want you to think about is, what is the campaign trying to communicate? Where is the stigma? Where do you see the stigma in the campaign? And what's the larger effect that it has in general? What's the larger effect that the campaign has? It may not be specific to what it's actually saying on the poster or the flyer, but what's the larger effect? So we're going to go ahead and unmute the lines.
The conference has been unmuted.
Okay, so go ahead and tell us, what do you think? Let's start with the first one about the sailor. What do you guys think that it's trying to say? And if you guys can go ahead and mute your phones so that we don't have the background noise. You can mute your own phones unless you want to say something, then you can go ahead and unmute yourself so you can tell us. So what do you think this campaign is trying to say with the first one about the sailors?
You can also feel free to chat your response under the chat box as well.
Okay, so we have here that this one is talking about that a sailor doesn't have to prove that he's a man. So there's no medicine for regret. So where do you think, if you look at the picture, you see the woman on the pole. So where do you think the stigma is? So maybe we have this woman, maybe it's saying, you know, hold on, we're going to mute the lines again. Okay.
The conference has been muted.
Okay, that's better. So we're looking at this one, and we're seeing there's this woman on a pole, and it's so basically, you know, people can look at this campaign in many different ways and can see different things when they see this and when they read this. So someone is saying that, let's see, that this addresses stigma that you have to have sex to protect, to prove that you're a man. So saying, okay, you're, in order to prove that you're a man, you have to have sex. This is fine. Someone else is saying that this is, this is fine with homosexuality, but remember to still be safe. So that it's okay to be gay, but you have to also be safe. Okay, so again, this is different ways that people interpret these campaigns. But some things that we've seen is that people have said, oh yeah, don't have sex with a woman because that woman, she'll give you something. And okay, someone else read it this way, that sailors have sex with prostitutes, which may be true, but it may not be true. So again, this is the different ways that people can see these campaigns, right? So let's look at the next one. This one is the venereal disease covers the earth. Learn to protect yourself now. So what do you guys think about this one? You can put it in the chat box. What is this campaign trying to communicate? What is it saying? Okay, we haven't had any answers. So let's see. So it's talking. Okay, so it's saying that women are a disease. Okay, that like, okay, so like it as a general message, perhaps change the image for different populations. Okay, you can only get venereal disease from women. Red is also a color used for prostitutes, right? It clearly labels sex workers as the spread of the disease. It shows women harbors diseases. Diseases is everywhere. Sorry for the cause. Okay, so for the cause, let's see. It's clearly labels sex workers as spread of the disease. So for the cause of the spread of the disease. And also red to get attention. With this which this message hopes to do. Yeah, so and in this one we've actually seen a whole bunch of different reaction, or it may be that it's encouraging women to protect themselves. Someone else said, someone says that they don't see it as stigmatizing. So again, this is the different ways that we may see things. So some people may see it as like, oh well, it's telling a woman, okay, be careful, it's all over the place, so protect yourself. But others see it, and actually what we've seen, which is the higher rates of people that have seen this, is basically that it's saying that women are the venereal disease and protect yourself. So that's how some people have seen it. Okay, so some of you are saying that it's misleading in terms of risk. And even though she looks wealthy, well-dressed female, she is portraying an image of being highly sexual or promiscuous. Right, so these are the different things that we've seen. And the effect of this, the larger effect is that maybe people see, okay, well, women are this. And if you look at this picture, it looks like an older picture. So maybe from the 50s or 60s, or maybe even earlier. And at that time, we all know that it was before we had the women's rights movement, etc. And then we have someone that whether stigma affects us is independent of how well adjusted and self-accepting the interpreter is. That's right. And we're actually going to talk about how culture and our different cultures have an effect on how we see things and how we maybe stigmatize or how we interpret different things. So let's look at another two campaigns. So we have one here. On the left, you don't always know where he's going home to get tested for HIV. This is a more recent campaign. We have another one here, no condom for money is a trick. another different. These are more recent campaigns. So these are just examples of different campaigns, and some of them people may see them as stigmatizing, others don't. Other people feel that some campaigns have worked very well and have actually have had an impact in our communities. Okay, so now let's talk about how culture affects stigma. So we want to ask you, take a look at this picture and tell us, what do you see? Put it in the chat box.
So what do you think is going on in this picture? And if you feel more comfortable bringing it up over the phone versus chatting, you could also unmute your line.
You can unmute your line by pressing *7.
Someone is saying, penguins getting ready to jump into the water. Okay. Penguins playing in the snow. One is telling the others a story. Okay. 3 penguins with one getting the attention of the other 2. Looks like a penguin is trying to get the other 2 to jump in the water. Okay. So we see that maybe one is warning the others. Okay. So we see that even though we all see the same image, we all interpret it in different ways. And the way we interpret this image has to do with the way we've been brought up, or the way our cultures influence us to view things in the world, right?
And actually, when we've shown this picture in other places, we've seen a wide array of answers. Someone just said peer pressure. Yeah, and we've seen people say, oh, 2 of the penguins are telling the other one to go away, and they don't want to be around him. The other ones are saying they're about to fight, or a mating call, someone just said. Right, so these are different views that people have. Go ahead. So, and this is what we were mentioning about culture. So our different cultures may influence the way that we see things.
So who can tell us what culture is, or give us a definition of what they think culture is, or give just different aspects of culture? And you can do this again by giving your answers through the chat box, or unmuting your line by pressing *7. So who can tell us or give us ideas of what the definition of culture is, or different aspects of culture? Someone is saying a body of acts, traditions, language which are shared by a group of people, a group of beliefs about a certain segment of society. Okay. It is our beliefs and actions, the foundation which one is conditioned over, the environment and influences you are raised with. So there's an array of different ways we can interpret culture, and we see there's an ongoing sharing of similar words like beliefs and values and society and groups. So it definitely has to do with a collection of people, right? And behaviors. So we have some more answers that we have are groups of behaviors and actions in a certain set of people. They're agreed upon values based on through groups. Passed on through groups. I'm sorry. So here are some cultural competency basics. So in terms of how can we interact with certain cultures better and understand them better, we've provided a series of certain basic things that could be done. So as a definition, we have culture is a shared identity, either defined by oneself or imposed by others, often brings people together in groups, assumed to have common beliefs and values, thus forming cultures. So as you can see, much of what a lot of people have said so far is mirrored in the definition that we provided here. Culture is a set of unspoken rules. Culture defines the way we see things and the way we are seen, a cultural lens. Culture can link and alienate people within the culture and outside of it. Culture is complex. It could be highly individual, and it could be institutional. So what we're going to do now that we've provided an overview of what culture is we're going to have another poll. So this poll is, to be culturally competent, so be able to interact with the culture appropriately, is it best to be part of the particular culture? So do you have to be part of that culture to be able to be culturally competent? And so it's either A, true, B, false, or C, unsure. And we're going to open the poll now. So here we have again, to be culturally competent, is it best to be part of the particular culture? So feel free to answer A, true, B, false, or C, unsure. Okay. So it seems like the majority of people have answered, so we're going to go ahead and close the poll. As you see, the majority, over 50% of the group, said that it's false. So the majority of people said that you don't need to be part of the culture to be culturally competent. So in many ways that's very true. You don't oftentimes have to be part of a culture to be culturally competent, even though that question I think was phrased in a pretty tricky way, because it did say best. So oftentimes people do think that the best way to be able to be culturally competent is to be part of that population. But that's not always true. You can be culturally competent without being part of that population or culture itself. So we want to define what cultural competency is, or what is cultural competence. The definition we have here is having the capacity to function in a particular way within the context of a culturally integrated patterns of human behavior defined by a group. And this can occur in an individual level, an organizational level, or a societal level. So this could be based on the way you interact with one person, the way you interact in an organization. Can you be culturally competent to interact with an entire society? So the way you are culturally competent doesn't mean you have to be a collection of people. It could be one-on-one. So it could be an interaction between two people and whether both are being culturally competent of one another. It's especially salient when we talk about health services, HIV and AIDS prevention, and care, and stigma. Someone brought up, I think it's necessary to be culturally competent, but believe being a part of a culture provides insight gained from the experience in the culture. Right. So it definitely has to do, like I mentioned before, in the way the question was framed. Being part of the culture does, what we say, give you a leg up in terms of being culturally competent, because that is your culture, but it doesn't mean that someone that isn't part of the culture can't be culturally competent.
And here we'll give you basically something to think about. So we have a Zimbabwean woman who goes to a hospital with stomach problems. An American male doctor tries to examine her, but she is uncomfortable and refuses examination. She does not know how to speak English very well, but her son does. The doctor tells the son that they want to keep her overnight for observation. So some of the things to think about in this situation. Maybe the provider should think about the healthcare beliefs. So what are their beliefs? What are the social norms about examination? So maybe it has to be a woman that has to examine her. So maybe the doctor doesn't have to keep her overnight as long as a woman can examine her and then be able to tell right away what's going on, right? So maybe the language. Do they have an interpreter on site, somebody that can go ahead and translate what's going on? Translation ethics. Again, we also have guidelines and rules on translation, and especially in the healthcare field as well as the legal field, for example. So these are things that the provider should always be thinking about when it comes to these types of situations. So we have another poll, another question we have. So what keeps us from being culturally competent? What do you guys think? The first answer is A, is inability to recognize the differences. Thinking that differences are not significant, or that our common humanity transcends our differences. C, challenging and intimidating to understand something that is new, that does not fit into one's world view. So it's challenging. And D, feeling rushed and unable to look in depth at an individual's needs. So we're going to go ahead and open the polls, and if you guys can let us know, what do you think? What keeps us from being culturally competent? and I can read them off to you again. A, inability to recognize the differences. B, thinking that differences are not significant or that common humanity transcends our differences. C, it's challenging and intimidating to understand something that's new, that does not fit into one's worldview. And D, feeling rushed and unable to look in depth at an individual's needs. Okay, so I think that's everyone. And let's see, what do you guys think? So everyone mostly answered B, thinking that differences are not significant or that our common humanity transcends our differences. The second highest answer was inability to recognize the differences. So if we look at these answers that you guys gave, we look at those, we see that word is common in both answers, is the differences, right? So knowing that that culture has a lot to do with a lot of with differences. So let's look at these answers. So basically, all of these answers can inhibit us from being culturally competent. So the first one is basically the inability to recognize the differences. That's the lack of knowledge, right? So not knowing. The self-protection or denial. So you want to think, well, if maybe those other differences, the other differences, they're not significant, but that's because maybe you want to protect your own identities or your own beliefs and values. The other one is fear of the unknown or the new or something new. And the last one, feeling of pressure due to time constraints. So maybe you need to work on something right away. You need to meet with clients right away. You need to get people in the door right away, and you feel like you don't have the time to take the time to learn about the differences. And that's what culture has to do with. As I said before, it's these differences. So cultural competency applies to a range of differences. And when we think about culture, we think about, how are we different? The country of origin, the class, age, region, sexuality, ability, gender, religion, substance use, maybe the cultures within our own organizations, the different types of cultures. And I'll give you another example. This is a little anecdote. So this is a true story. This woman goes to the hospital she goes to see a doctor, and the doctor, she doesn't speak the language very well. She doesn't speak English very well. And the doctor is saying, well, you know what? Okay, how are you feeling? And she's like, well, I can't sleep at night. She's telling this to him in Spanish, because the doctor actually speaks Spanish. So she's telling him, well, I can't sleep at night. And the doctor's, okay, well, what's keeping you from going to sleep? And she's like, well, it's all these, she's telling him in Spanish, all these tigres. And she's actually Dominican from Washington Heights. And she says tigres, and to Dominicans, tigres are basically, guys in the street, just people in the street, guys or kids in the street. So the doctor doesn't interpret it as kids or guys in the street making noise. He interprets it as she's having hallucinations of tigers, and for that reason she can't sleep. So she ends up in a mental health institution for a whole entire month, just because he didn't understand in her language and in her culture, those are basically some slang, right? So that's why it's important to be able to take the time to really know who your clients are and who your audience is. And some of these, so that's why it's important to be culturally responsive. And what is cultural responsiveness? It's basically the technique of being analytical in regards to other cultures. So identifying the cultural norms of different cultural groups, and then being able to act in a culturally appropriate manner, even though the context may not suggest such behavior is necessary. So you may feel that it's not necessary, or in the context not necessary, but it's actually being able to respond to it positively and culturally appropriate. So we're gonna open up now. If you guys have any questions about anything that we've talked about so far, you can raise your hand and we can unmute your line. You can unmute your line yourself by pressing *7, and then you can go ahead and mute it again by pressing *6 after you've answered your question. You can also put it in the chat box. Any questions?
Don't be shy.
Okay, so we see we have no questions. So we're going to continue.
Great. So now what we're going to talk about are some factors that influence risky sexual behavior. And these factors are usually things that are due to stigma and cultural competency in terms of the way people are being, the way people interact with others. So we have racism, homophobia, poverty, traditional gender roles as examples that we have here. And in racism, it has been documented that racism affects the lives of people. Those who have experienced racism report more risky sex than those that do not. We also have homophobia. Greater layers of homophobia are related to more sexual behavioral risk. Individuals who are gay and who are exposed to homophobic family environments report levels of shame, loneliness, and isolation. We also have poverty. When individuals experience poverty, sexual safety might not be a priority in their lives. Some individuals might be forced to become sex workers in order to support themselves or their families. Traditional gender roles. Cultural coded gender roles may limit sexual negotiation and condom use, may place value on promiscuity, and create an imbalance in decision power regarding safe sex encounters. So sexual coercion, right? So these are some examples of factors that are imposed on others that might influence them to engage in risky sexual behavior. And what I'd like to ask you all is, even though we have racism, homophobia, poverty, and traditional gender roles, is if you all can think of any others aside from those that I've just mentioned that might influence risky sexual behavior. I'm sorry.
Okay, Flyboy.
So are there any others aside from racism, homophobia, poverty, and traditional gender roles that might influence risky sex behavior? Some people are saying self-esteem also influences. Risky sex is not fun, definitely not.
It's fun, she put.
Religion, machismo, culturally specific, definitely. Self-esteem and peer pressure, shame. Someone said risky behavior, risky sex is fun as a reason as to why people engage in risky sex behavior. Thank you. Definitely, some people definitely find risky sex as being more engaging. They find that arousing, having this thrill of risky sex. That's definitely going to be a reason to influence people to engage in it. A lack of education, that's definitely another factor that influences risky sex behavior. So people don't know that they're engaging in risky sex behavior because they don't really know how risky the sex they're engaging is. So definitely all those are very true, very true. So there's been an assessment that's been created that allows people to be able to assess how culturally competent they think they are, and this is done through a series of statements that a person is asked, and it's usually answered on a scale. So for each one of these statements, there's a scale, either how strongly you agree or how strongly you disagree with the statement. And by this, it can kind of help us gauge how culturally competent we are. So some of these statements include personalizing observations. So using I instead of you in your messages or when you're speaking to someone. Paying attention to your feelings, seeking to understand our own reactions. So why is it that we're reacting to a certain type of situation or environment or person in a certain way, right? Listening carefully. How able are you to listen carefully to verbal and nonverbal content? So the way someone's standing or their body language, not only what people are saying. And there's a series of these questions and assessments that that were created by someone named Dr. Michael Hogan Garcia, And some more of these statements include managing personal bias. So, how is it that you're able to, even though you have a preference for something over another, be able to understand that and negotiate it with yourself without making others feel uncomfortable, right? Or coming off as non-judgmental, stopping the tendency to negatively judge others who are different than yourself, right? So there's definitely a series of questions and statements that some might agree with more than others, and which makes sense as to why some of these statements would be on a scale. And from this type of assessment, we can kind of start gauging how culturally competent we might think that we are. So something we'd like to talk about now is cultural competence techniques. So how is it that we can be culturally competent? What we're going to introduce first as a technique is something called the cultural humility model. And this is covered by 5 steps that someone can do to start being better able to be culturally competent. One of them being to view the client as an expert of his or her own culture. So not imposing your own cultural beliefs on that person, but letting them be an expert of their own and working with them and negotiating over time in terms of how can you provide that service better.
And also so using that to, the client is the expert, so then using that for yourself to learn more about that client's culture, and you can use that client as your teacher to learn more.
Definitely. Use self-reflection and self-critique in interaction with the client. So be thoughtful of the way you're interacting with the client. Critique yourself in understanding, well, is this the best way to be interacting with this client? Am I being, is there anything that might make this client uncomfortable? So be critical of the way you're interacting with people, making sure that you're not, again, imposing personal beliefs on others, right? Practice mutual respect, and that's pretty much a golden rule, right? Treat others as you'd like to be treated yourself. So apply mutual respect. Make sure that you're not, again, imposing beliefs on others. Continuously research for knowledge of other cultures. So, making sure that if there's a certain population that you see that you're working with frequently, make an effort to learn about that culture. It doesn't necessarily have to, you don't have to go to a library to do some Google research. Again, as mentioned by Betsy a minute ago, even interacting with the client and asking the client questions about their culture is an easy way to start learning about the people that we're interacting. The last one being, be flexible and humble to recognize what you do not know. Oftentimes, because we are an expert in our fields, we feel that we know everything. But in terms of culture, people that we're working with might not always understand the messages that we are trying to deliver them, that were delivered to them, because we're not recognizing that we don't know as much about them as we should, so that we can cater and adapt these messages so that they can understand them. So being able to be humble enough to recognize what you do not know about a culture opens up the ability for us to learn about them.
So how can your own organizations be more culturally competent? Basically, organizations must support cultural competency by building strategies for cultural competence into their infrastructure. And even though ultimately the nature of interactions with patients and clients will depend on staff, organization must also support this culturally competent encounters by putting that into their infrastructure and providing the necessary supervision, for example, and protocols as another example. So how can your organization do this? Then you would have to engage into things like organizational assessments, environmental assessments, population segmentation, responsive service protocols, motivational interviewing, identity mapping, community mapping, maybe having an interpreter on site. So these are some of the things that you can engage in to make sure you have that infrastructure, which can help and increases cultural competence. That should be provided in all healthcare services. So some of the things that an organization should do to be culturally competent is basically provide an environment in which patients and consumers from diverse cultural backgrounds feel comfortable discussing their cultural backgrounds. Their cultural health beliefs and practices in the context of negotiating treatment options. Also, using community healthcare workers as a check on the effectiveness of communication and care. encouraging patients and consumers to express their spiritual beliefs and cultural practices, so being open enough to allow that. Knowing and respecting traditional healing beliefs, and beliefs that and systems and beliefs, and integrate them into approaches into treatment plans. So always keeping in mind the other's beliefs and values and culture, etc. So we're gonna go now also into ethics, and this is something that's also very important in order to have culturally competent organization, and keeping in mind ethics, it destigmatizes HIV status. So do your services destigmatize HIV? Think about back in the days when when we first found out about HIV, and people used to give out, the nurses, for example, would wear gloves, or even the front desk people would wear gloves in the HIV department. And when people would come in, if the person was HIV positive, they automatically got like a sticker. I don't know if it was green or red sticker on their hospital card, that definitely said, okay, this person is positive. So think about how we've changed, but what still needs to change? What other things are we doing that may stigmatize HIV with our services? And also being responsive to context of HIV exposure. We see that someone said that some folks still engage in these types of ridiculous behavior. That's true. And these are some of the things that we're trying to change. Acknowledge complexity. It acknowledges complexity of disparities within context of infection. Emphasizes strengths for behavior change. So where are the strengths? Organizes options in cooperation with the consumer, and model ethical interaction with consumer. So thinking about cultural competency and ethics in every service encounter. So not just HIV prevention, but also with everything else. And then we've been given some standards. These are the national standards for culturally and linguistically appropriate services in healthcare, and these are basically these are available at this link that you have here, but also you can just go on the HHS website, or the Office of Minority Health website, directly, and you can find them there, the standards. And these standards are basically, actually they are requirements for us to follow whenever we're providing healthcare services. And actually striving for cultural competence is important in implementing some of the various sections of the National HIV/AIDS strategy that we've seen. And as you go, if you will be attending these institutes and the other webinars that we'll be doing, you'll notice we'll talk a lot about the National HIV/AIDS strategy, because that's the new way. That's basically, it's kind of like the new era of HIV and AIDS. So always keeping in mind that cultural competency is definitely important and vital in order to be able to implement those recommendations in the strategy. So any questions so far with anything that we've talked about? We have come to the end of the webinar. We still have a few things that we're going to talk about before we finish, but for this part, do you have any questions so far?
Right, so as Bessie mentioned, in the last leg of the webinar, we do have a couple more slides to talk about the Institute in terms of registration and logistics. So if there's any questions in reference to what we've covered so far, please feel free to jump in and ask via the chat box, or by unmuting your line and pressing *7. And thank you so far for people that have been chatting and engaging in the poll so far. It's been a very interactive experience so far compared to some of the experience you've had in the past. So thank you for that. Thank you for that.
Okay, so we have no questions.
So like I mentioned, we're going to be talking about the schedule and logistics in terms of what the Texas HIV/AIDS Training Institutes will look like. To start off with, we'd like to say that we do have 2 more webinars coming up. The next one is going to be on Evaluation 101, and that's going to be taking place on the 18th, once again starting at 10 a.m. like this one did. And the last one before the Institutes is going to be taking place on January 20th at 10 a.m., which is about new directions in HIV, and that's the one that's going to be talking about the National AIDS Strategy and some of the things that we should be mindful of in terms of making sure that we understand so that our organizations are sustainable. So make sure you mark your calendars for that. There will be email reminders for those as well. What we're going to do now is kind of talk about what the institutes and the community forum will look like. So the community forum is going to be taking place in Austin, and that's going to be taking place on the 8th of February. And this is different from the track institutes, where those are going to be more like workshops. The community forum is going to start off with a panel and a welcoming presentation from 11 to 12:30, and then we'll be breaking up into different discussion groups, roundtables. We'll be discussing several topics, which are coalition building, cultural competency, AIDS stigma, funding needs, new directions in organizational sustainability, and we'll do that for about 2.5 hours, of which should include lunch. And finally, when we're done with the discussion of roundtables, we'll go ahead and break out into reporting what we found in each individual group and discuss potential action steps from them between 2 and 2:30.
Someone asked, where is the forum taking place? This forum is going to be in Austin.
In terms of a venue, that's still being decided on. Once we do solidify a venue, we'll be letting you guys know, which should be done within the next couple days. So you should receive an email by next week letting you know the exact locations for the forum.
And then the format in Houston will be different, but we're going to go over that. This is the way, what Tony's going to go over now is going to be the format in Houston.
Right, so the way the community forum is different from the sessions in San Antonio and Dallas, and also in Houston, is that they're being broken down into workshops. So it's going to be a day-long format in sessions, and there's 4 different checks. So we see that we're going to start each day with an open plenary between 8:30 and 10, and then we're going to be having a registration sign-in, and also an open plenary and welcome. And then after that, we'll be breaking up into individual tracks. So each person gets to attend one track. The first track is understanding and mobilizing communities. The second one being enhancing client interactions. Third, staff development. And fourth, organizational sustainability.
And
so
what we've seen so far is that people that have registered have actually registered in different cities, so that they're able to also attend the different tracks. So let's say you register in San Antonio, and you'd like to do track 1, you go to that, and then maybe you go to the Institute in Dallas, and then you'll register for track 2. So we've seen that people have also done that.
And because we know that in Houston there's a larger number of people that are interested in attending, that institute will be 2 days long. So we will be mirroring the first day on the second day. So we'll be implementing the tracks, the same tracks on the second day in Houston. So the one in Houston is 2 day long, versus the one in San Antonio and Dallas are only 1 day long. So we're going to go into a little more depth as to what each track covers. The first one, like I mentioned, was understanding and mobilizing communities, and the target audience for this is line staff. And the level is between intermediate, between beginner and intermediate. The goal being to develop skills that will allow you to deepen your understanding of and connection with your target communities through assessments, how to be better culturally competent, how to build coalitions, and how to evaluate the work that we're doing. So how is it that we can evaluate our efforts and making sure that they're fruitful? In each one of the tracks, there's a pre-course work, or what we're calling homework. And for this particular track, the pre-course homework is reviewing of an EPI report and filling out a personal leadership assessment tool. And once you register for each track, we'll get a list of those people registered for the track, and we'll email you this information so that you can make sure to have it done prior to attending the track itself.
And someone else asked if you can come to one track and attend the other on the second day. Yes. So the tracks are just 1 day long. So you may attend one day and then a different one on the second day.
If you're in Houston.
Yes.
If you're in
That's
Houston.
for Houston, yeah.
Right. But again, in San Antonio and Dallas, there's only 1 day. So you would have to attend one track.
Yeah.
Throughout the entire day. So Track 2, enhancing client interaction. This one is also directed towards line staff, and it's between intermediate and advanced in terms of the level. And the goal is to develop skills to examine and exchange successful ways of recruiting, retaining clients, and innovative prevention and treatment programs through the use of social networks, social media, and evaluation. And this is a pretty exciting tool. This is the first time we're going to be implementing something like this, because it's very heavily weighed on the use of social media and those tools to kind of recruit and retain our clients. So how is it that we can use social media like Facebook, Twitter, and things like this to interact with our clients and engage them and maintain communication, and have these other ways of communicating with them that might supplement the methods that we're currently using right now. And the pre-course homework for this one is to participate in the Evaluation 101 webinar, and that's the one that's going to be taking place next.
Yeah, so be sure if you plan on attending this track, to participate in that webinar. Be sure to attend the webinar. And someone asked if we're going to be emailing these slides. We are. We're going to send these. We're actually going to put them up on a website. Will you be able to log in and download the webinar, and it'll be recorded, so you'll be able to listen to it.
Right. So we also, like I mentioned at the beginning, we are recording this webinar, so it will be posted online for people that weren't able to attend to view.
And so we're going to move on to track 3. Track 3 basically is for managerial or administrative staff, and the level is intermediate to advanced. And in this track is basically to build skills in assessing and creating development plans for managerial style, staff growth, personal and staff burnout, and leadership development. So a lot of basically staff development, or that's the name of the track. So some of the pre-institute work will be the self-assessment of management style. And again, as Tony said earlier, once you register for the track, once you register for the institute and you pick your track, you'll receive all this information and all this pre-institute work, homework assignments. And then track 4 is on organizational sustainability, and the target audience is managerial administrative staff. It will be intermediate to advanced, and this one is to build capacities to help adjust to the current changes in HIV/AIDS services. So again, we want to make sure we keep each other up to date and with the wave of the future, right? So we're going to talk about enhancing program design and using evaluation for fund development and for program design, which are the 3 pillars of sustainability. And the pre-institute work for that is basically to bring your mission of your organization, an annual report if you have one, and a strategic plan if you have one. So that's the pre-course work for that. And again, for all of these, it's these webinars that are going on now are basically webinars that are applicable to all tracks. So we really encourage everyone to attend all the webinars. And these tracks are going to happen with the mindset that you guys have already attended the webinar. So they'll definitely be useful to you by the time you go for the tracks.
Something I'd like to mention is that even though there's a target audience for each track, it's not a requirement that you are part of managerial administrative staff to attend. You are free to attend any track as long as you feel comfortable and being able to attend and find it beneficial.
Right. And applicable to your work. So basically, to register, I'll show you where you will register in the next slide, but you would register for any of the institutes. Of course, you can register for more than one. If you feel like you want to attend 3 tracks, then you can register for, or 4 tracks. You can register for Austin, Dallas, and Houston. That's up to you. But you can register for the institutes, and then also, of course, the community forum that will happen in Austin. So basically, once you register, you would choose your track, then you would do your homework, and part of that is also attending the webinars. Then you would come to the institute. Lunch will be provided at the institutes, and also there's opportunities for networking, and of course this is going to build the capacity of your organization and your own work, because you'll be able to foster partnerships and collaboration. And then also you can come to the community forum that will happen in Austin, and that's actually a separate activity.
And to reiterate, the institute is completely free, so there is no charge for attending. So feel free to disseminate this information to your colleagues throughout the state, and make sure you try to get as many people that you know that would be interested to attend. So this is something that's been specifically developed and catered and created for Texas based on feedback that we
received through the community assessment we did there,
so
or the Texas assessment.
it's very much catered to the needs of Texas service providers. So it's specific to what you've told us is important to you.
And then, so to register, you would go to the website, to www.surveymonkey.com/s/tx registration. If you want to write this down, but again, we're going to have this up, or you can contact Natasha Kirch directly, and she's the program coordinator for our Capacity Building Assistance Division. And her email address is nquirch@latinoaids.org. And her number, you can also call her at 212-675-3288, extension 316.
And last thing before we part ways, there is an evaluation form at the end of this webinar. So please make sure you fill this out. It's very important that we receive your feedback just so that we can continue to improve our efforts in the delivery of our services. Once the webinar is over and once you close your window, this survey will pop up. So please fill it out, and we'll also be emailing the evaluation for the survey at the end of the webinar. So please take a minute to fill that out. It'd be greatly appreciated.
So wait for us to log off, and once we log off, it'll show up on your screen, so you can go ahead and fill that out. So the dates for Houston, I'm not sure exactly when, but we'll probably have that sooner rather than later. So by the end of this month, we will hope to have that. If not, we'll definitely keep you updated. So yes, we have that in mind about HCV month. So we'll keep that in mind, and we'll definitely give you the dates as soon as we have them. If you guys have any other questions, please let us know. You can either raise your hand, you can unmute your lines, you can also email us directly. We're not sure exactly when in April, but we'll definitely let you know. But we have a feeling that it will be in the beginning of April, so early April, we're thinking. Okay, so any other questions? Thank you so much for participating in this webinar. You guys have been great. We've gotten a lot of feedback from you and a lot of participation in the chat. So thanks again for participating. I'm Betsy Morales, and this is
Tony. And again, our emails are displayed on the screen now. So if you want to ask us or contact us for anything else, feel free to reach us via email on the emails displayed there. Great. Thank you so much. Have a great day.
Yep.
This conference is no longer being recorded.
People were asking about the slides. We have to email them and tell them because they kept asking. Someone else asked again.
No.